Good morning, everyone. My name is Charlene, and as a clinical education specialist at InBody USA, I want to welcome all of you to today's webinar in our InBody Presents series. Today, Ms. Whittney Thoman will be speaking to us about the importance of body composition analysis with her work in the cancer prevention setting. Ms. Thoman provides operational management and guidance for the Healthy Living Clinics and Healthy Heart program within the Cancer Prevention Center at the University of Texas MD Anderson Cancer Center. Currently, she leads the clinical team, providing IH services for prevention and survivorship patients, as well as direct projects and clinical operations initiatives. Ms. Thoman is a certified ACSM clinical exercise physiologist, cancer exercise trainer, and exercises medicine level 3 credentialed exercise professional. At the end of the talk, attendees will have a chance to ask her questions by adding them to the Q&A section on your screen. Now, I would like to welcome our guest speaker, Ms. Whittney Thoman, to join us.
Hi guys, good morning. So today I'd like to talk a little bit about the importance of body composition and analysis in our cancer prevention setting. So I work in the Lyda Hill Cancer Prevention Center at MD Anderson. The Lyda Hill Cancer Prevention Center was created to offer a range of services to help patients learn how to reduce their risk of cancer and detect cancer early. And we do lots of screenings that are age-based, gender-based, and on disease risk. These are the services that we offer within the Cancer Prevention Center. So we do screening, we do breast screening, we do cervical cancer screening, colorectal cancer, prostate cancer screening, skin cancer, and lung cancer. And along with all of those, we also offer several clinics and programs. So we have the undiagnosed breast clinic, which is where we send patients who come in for their screening and there's a mass detected. We have the same for our undiagnosed dermatology clinic and undiagnosed gyn. We also offer the Healthy Heart program and the Healthy Living Clinic. I am in charge of both of those programs. And so I'm going to talk a little bit about those programs today and how we use the InBody with these programs. So the first one I'm going to talk about is the Healthy Living Clinic. These patients are the healthy patients that we see without a cancer diagnosis in the Cancer Prevention Center. And the purpose of this clinic is to educate patients on the guidelines for cancer risk reduction regarding nutrition and physical activity. And then if the patient is interested, we create kind of some goals around exercise and diet. I can create a custom exercise plan, and we will follow up with the patients periodically to make sure they're kind of sticking with these goals and plans. So as we kind of developed this clinic, it's a relatively new clinic, we decided that we also wanted to offer a more intensive weight loss program. So 2 years ago, we created the Healthy Living Clinic Weight Loss Program, which is modeled after the Diabetes Prevention Program. It's evidence-based, approved by the CDC. The goal for this program is that each patient lose 5 to 7% of their body weight in 16 weeks. And we kind of thought this was a great kind of program for our clinic because cancer is associated with similar behaviors as diabetes, such as obesity, low physical activity, poor diet. So we initially started this amongst MD Anderson employees to determine the clinical and operational feasibility, since it's kind of hard to get into the Houston Medical Center on a weekly basis for 16 weeks. And as of 2020, we rolled the program out to our patients within the Cancer Prevention Center. So this is just a little bit of information. Our first cohort, we did not have the InBody. So we got the InBody right as we were kicking off our cohort 2. And so here you can see some weight change over the 16 weeks in cohort 2, the skeletal mass, muscle mass change, and then the percent body fat change. So far, we've completed 5 cohorts, and we've had about a 59% retention rate. And that's mostly just because of the difficulty getting into the medical center and having an appointment weekly for 16 weeks. The average weight loss has been 7.3 pounds. And of those who lost weight, the average weight loss is about 10.6 pounds. We have used the InBody for all of the cohorts except the very first and our current cohort, because we are doing a telehealth-based cohort with them. But these are some of the improvements that we saw after implementing the InBody in this program. It kept our patients more compliant, more engaged, more educated. It was great data to kind of share with the multidisciplinary teams, like their physician within MD Anderson, their dietitians. We used it between ourselves with the health education specialist and the exercise physiologist to kind of come up with a more customized plan for these patients with their diet and exercise. It showed a lot more motivation and compliance with our patients because they could see more than just weight loss over time. And then it kind of gave an immediate understanding of their health status, which gave us a great discussion point to talk to them about. And it was very cost effective and quick and non-invasive. The second program I oversee is the Healthy Heart Program. This program was created for patients with a cancer diagnosis. So they can either be in active treatment or kind of in that survivorship phase of their care. And this program was created to help mitigate the cardiovascular effects that patients have after their cancer diagnosis and cancer treatment. And so the patient will meet with a cardiologist and have a consult. And then pre-COVID, we were doing VO2 max exercise tests on them and then creating a customized exercise plan. We've had to take out the testing just because all of our visits are telehealth based now, but we still give them the prescribed exercise program. And this just kind of is a little bit more information on why this program was created. So when patients have a cancer diagnosis, it's kind of a multiple hit issue because they have their baseline risk factors such as obesity, hypertension, age, and then they have the direct injury, which is their anti-cancer therapy, whether it's chemo or radiation, which can have a long-term effect on the heart. And then they have this indirect injury, which is during their treatment, which is kind of secondary to their therapy, which is usually deconditioning due to lack of exercise, and then weight gain either due to lack of exercise or some of the steroid treatments that they receive. So that's why we created this program, was to basically mitigate all of those effects by getting these patients to exercise on a regular basis. The most common cancer types we see in clinic are breast, gynecologic cancers, colon cancer, thyroid cancer, prostate cancer. MD Anderson has just opened up a new survivorship program. It is the young adult and adolescent cancer survivorship program. So we see a lot of their patients who've had sarcoma or lymphoma or leukemia in our clinic as well. So here's kind of a little breakdown of the InBody parameters that we use based on a patient's cancer type. We look at their skeletal muscle mass for our prostate cancer survivors or prostate cancer patients because they are put on ADT therapy, which is androgen deprivation therapy. It decreases their testosterone and they often gain a lot of weight and they also lose a lot of muscle mass. So it's a really good indicator for that group. Then we also use it in our leukemia patients because they tend to have a very significant amount of muscle loss. And so we look at if we can increase their muscle mass with our exercise program. We look at the body fat mass or percent body fat with our breast, gen patients, and prostate patients, mainly because breast and gynecologic cancers, you're at a higher risk the higher your body fat and body weight is. So we like to kind of see them lose body fat mass along their trajectory with us. We use the segmental lean analysis a lot in our sarcoma patients due to the surgeries that they have. Often will have a limb replacement or a prosthetic. So we'll look at that with them. We use the basal metabolic rate with our thyroid and breast cancer survivors because they typically have the most weight gain. And we can kind of give that information to the dietitians as they work with. And we also look at the visceral fat area in the prostate and colon patients because that can increase their risk over time for a recurrence. This is just kind of the patient pathway. And this is the same for our healthy heart patients and our healthy living clinic. The only difference is the healthy living clinic patients don't get the CPET or the 6-minute walk test. So their very first visit, they'll have the following assessments. They'll get the InBody done. They'll have a 6-minute walk test or a cardiopulmonary exercise test, a 5-second sit to stand, lab work if needed. They'll get an exercise prescription and a referral to a dietitian if needed. Then we kind of follow up with the exercise intervention. For most patients, it's about a 3 to 4 month intervention where I or another health educator will follow up either via text or telehealth visits or email, and we provide weekly education via MyChart. And then the patient will come back in 3 to 4 months and repeat all of the assessments, their InBody. Sometimes we don't get to do very many repeat cardiopulmonary exercise tests, but we do get to do repeat 6-minute walks, the 5 times sit to stand and lab work, and kind of review or tweak their exercise prescription based on the assessments and how they've improved their body mass. We've also been able to use the InBody in a couple of our clinical cancer prevention research studies. I actually am helping with this study. It is a cycling intervention, as in like bicycling, and it's for Lynch syndrome patients. Lynch syndrome is an inherited condition that increases a patient's risk significantly for developing colon cancer, endometrial cancer, and several other cancers at a very early age. And the scary thing about this is most people don't know they have it until they receive a cancer diagnosis. And then once they've received a diagnosis, they've already had children who they've passed this on to. So kind of the aim of this study was to do a feasibility study of a 16-month-long cycling intervention with these Lynch syndrome patients. And then we were going to look at some of the biomarkers, if their weight changed, if their VO2 max changed, and kind of see how that correlates with patients who didn't do a 12-month exercise intervention. So we did use the InBody for that. We just don't have the results yet to be analyzed, but I'm looking forward to kind of seeing the data that gives us. And we are also using it in another study with our prostate cancer, metastatic prostate cancer group who are receiving ADT. Because the ADT tends to decrease their muscle mass and increase their body fat and weight, it also has a significant impact on their cardiovascular health. So we are doing a 4-month exercise intervention, strength training based, to see if we can kind of change those metabolic outcomes in patients. Especially we want to look at if it has changed their PSA, we want to look at if it's changing any biomarkers, their impact on quality of life, and their impact on body composition. Some key reasons we will continue the use of the InBody in our Cancer Prevention Center is it has helped us enhance decisions based on muscle, fat, and we don't use water much in our clinic. There's another clinic within the institution that uses it a little bit more frequently, but it gives us a better result than BMI to kind of look at outcomes and success rates. It gives us the ability to tailor our exercise and nutritional interventions to the patient's body composition. It's quick and very non-invasive compared to the DEXA, which is the only other option that we have in our institution. So we very much prefer the InBody for that. It's a great way to educate our patients, and we've seen much more compliance and much more interest in especially the strength training when patients actually see their muscle mass increasing. It gets a lot of them very excited. And then of course, we see the overall risk of disease reduced in our patient population. And that's all I have.
Great. Thank you so much, Whitney, for sharing the great work that you are doing in the cancer prevention centers, at MD Anderson. We are so thankful to see that we have, frontline workers like yourself, really taking that action to help patients not only understand the treatment you're providing them, but help them become more aware and more engaged in what they're doing, with the work that you are doing with them.
Yes.
So at this time, we would like to ask you some questions from our audience. Again,
Absolutely.
as a reminder to all of our attendees, feel free to send in your questions to Whitney using the Q&A chat box at the bottom of your screen. But there are some that have come in for you already. Um,
Great.
so the first question we'd like to ask you, Whitney, is as a preventive approach for cancer, how are the patients selected? Is it family history, previous cancer? Additionally, how are they being referred to you for treatment?
Absolutely. So most of the patients are actually self-referral. So they will call and they will say, I'm interested in getting my breast screening done at MD Anderson. It helps that we are the #1 cancer institute in the US. Um,
Mhm.
so a lot of patients are self-referral, and then there is also provider referral from within the institution. So let's say there's a patient who has a history of sarcoma, their oncologist may refer them to our center for their breast screenings, gen screenings, those type of things. And then every new patient that is scheduled in the Cancer Prevention Center, or CPC is what we refer to it as, is scheduled with a healthy living provider on the day of their first consultation. Um, and so it's a little bit education based that day, but then if they want to go further into the exercise or the weight loss program, then we'll take it from there.
Awesome. Thank you for sharing that. And I think it's so great that education, as you mentioned, is that first step, um,
Yes,
because it's kind of hard to get someone to follow through with the program if they don't really understand it beforehand, right?
exactly.
Awesome. So, could you elaborate on how, or if there were any specific instances where patients maybe became more compliant or engaged, either through multidisciplinary team communication or in seeing clinical decisions improved by using InBody as a resource?
Absolutely. And so I think our weight loss program is kind of a key for that, because along with the weekly education that they were getting with the health educators, I offered once a week on Tuesdays a couple of different hourly sessions in our employee fitness, our employee gym. So this was only
Hmm.
offered to the employees so far. But they would come in and I would do like a didactic, this is how you use a treadmill, or this is how you use dumbbells, this is how you use resistance bands. And so we saw a lot of those participants increase their muscle mass as well as lose some body fat. And so that like really kind of like fueled the fire for them. And we've also had several of those people, once they've kind of graduated from the program, contact us to come back for follow-up. And they're, the first thing they ask is like, can I do the InBody? I want to see how many more changes I've made. So we're like, oh yes, absolutely, of course. So I think those are a really good indicator. And I've also seen it work a lot in the adolescent and young adult cancer survivor population. Um, and I joke around with my boss sometimes. I'm like, it's because it's a vanity thing for them, especially in boys. They want to, see how much muscle mass they've added. They'll be like, I've added so many pounds to my bench press or to my squat. Like, let's see how it correlates with my actual, body. So they enjoy it
Right.
too.
That's awesome. It's also you can kind of create some healthy competition with their results,
Yes.
right?
Yes.
Now, in speaking of, your client engagement and your retention, I did notice on your slides that there was a retention rate of about 59%. Do you
Yes.
envision ways of increasing that retention?
So we've seen, because we've launched, because we're working from home currently due to COVID, we have launched a telehealth model of this weight loss program. And that has actually, it's it's increased retention because the patients don't have to come into the medical center weekly. So it makes it easier for them to kind of do the program, but we've seen a little bit less engagement, I think, because we don't have the data from the InBody to kind of show them over time. And predominantly our patient population is female, they're middle age, and so they get really frustrated over time if they're like, I've made all these changes, but the scale isn't moving, and we don't have this extra information to show them your your body scale weight may not be changing, but like look at all these other parameters that are changing, and you're making a big difference. So retention, I think the best way to kind of combine retention and engagement would be to see the patient like first visit and last visit in person, do the InBody, and then keep the rest of the visits telehealth based so that it's not such a burden to get into the medical center.
Right. Thanks for sharing that.
You're welcome.
Now, we do have another question for you. Would you be able to share what the financial requirements for a patient to be a part of this program are?
Did you say financial?
Correct.
Yes. So for the Healthy Living Clinic or the weight loss program, it's actually if you are a patient within the Cancer Prevention Center. So if you've had screenings, it's actually free. We offer it at no charge to these patients. And then the Healthy Heart program, you would pay your specialist copay to see the cardiologist, and then the rest of it is free. So you're essentially paying your copays to see the provider for the screenings or the Healthy Heart consult, but there's no actual fee tagged on to the services, if that makes sense.
That definitely does. And that's great. I mean,
Yeah, we are working on figuring out a way to tack on a little bit of a small fee, mostly to make our program sustainable, because we were actually, the reason we were created was by a huge endowment from the Duncan family. So they kind of take care of all of our financial things for us. And so that eventually we will need to become more sustainable on our own.
Got it. Good to know. So if anyone here is listening, who's part of of
Yes.
your facility, there you go, free of charge.
Yes.
So we have another question here for you. Could you explain what is ADT and how does InBody benefit this treatment or therapy?
Yes. So ADT is androgen deprivation therapy. So what they prescribe this to prostate cancer patients, and essentially what it does is it lowers the testosterone levels in their body, because prostate cancer is fueled by testosterone. Um, and so what happens when their patients' testosterone is lowered, they tend to gain a lot of weight, especially kind of in their midsection, which then puts patients at a higher risk for other cancers. They lose a lot of muscle mass. So that's why the InBody is really important for us as we create an exercise prescription for these prostate cancer survivors, is because we want to see kind of that inverse relationship where they're gaining muscle mass, getting stronger to kind of carry out their everyday life, and then losing weight or body fat or even visceral fat to reduce their risk for other types of cancer.
Got it. Thank you for explaining that for
You're
us.
welcome.
Now, you did mention DEXA as part of your presentation and how that is also used at your facility, but it's not as efficient
Yes.
for your population. Could
Yes.
you explain how, the InBody is different from other body composition measurements such as bod pod if you've used that in the past?
Sure. So the last time I used a bod pod was when I was in graduate school. So quite a while ago. And I think for our patients, why we chose the InBody instead of something like that. Number one is space. It takes up very little space. Also, two, in a bod pod or other devices similar to a bod pod, patients kind of almost have to strip down, either into like a bathing suit or underwear. And our patient population would not be comfortable doing that in kind of the clinic that we have. So they can, our patients can stay dressed, other than their shoes and socks, of course. And then it's also, I've heard lots of people complain that a bod pod and the DEXA can like make them feel claustrophobic. So this is a good, it's just like stepping on a scale essentially.
Right. And I think even more to add on to that, like outside of the device itself, even the parameters that you get are different, right? You mentioned
Yes,
skeletal muscle mass being important. And with the InBody, we know it does provide those segmentally as well, and
absolutely.
other, you know, the trend line of history that you even get with it, right?
Yes, and that has been huge for our patients. They love to see that trend line, because a lot of them are very data driven, and so seeing that trend line has helped a ton.
Right. Now, speaking on that trend line, how
Sure.
often do you test patients on the InBody? I'm aware it might have changed now with COVID and everything.
Yes.
Um, but prior to, how often were you testing?
So we were doing, with the weight loss program, we were doing the initial and then the post, so baseline and post, and that was 16 weeks. Our Healthy Heart program is kind of the same. It's a baseline and then 3 to 4 months, so anywhere between 12 to 16 weeks. We've had people, especially with the weight loss program, because they were employees and they were there, they would want to, use it every week. And so I recommended, just based on my own experience with using the InBody, for them not to do it more than once a month or every 6 weeks, just because there aren't going to be huge significant changes in the things that we were looking at. So unlike a regular scale where people would jump on daily or weekly, we kind of kept it to about 4 to 6 weeks for our patients.
Got it. Along with your recommendations on test time, do you have any recommendations or limits onto who can participate in the program? For example, can you have a young pediatric cancer survivor patient be part of your program?
So we cannot have a young pediatric patient. Our parameters for anyone seen in our center is that they have to be over 18. Or 18 or older. And so as soon as they hit that 18 mark, we can see them. The other thing is that for the healthy living, they do have to be a patient who receives a screening within the center. So we don't just see like outside, when we don't see patients within the institution who haven't come through the prevention side. So as far as like the healthy living portion, I couldn't see a patient who was seen in lymphoma unless they were referred to the Healthy Heart program, and then I could see them, if that makes sense. It's a little confusing.
That definitely makes sense. And just to remind you, Whitney, we are getting a lot of thank yous in our Q&A chat box from our audience. So everyone is loving your presentation. I know on our end, we definitely are excited to have you here. Are you looking at doing any research with patients who develop lymphedema?
So we in our center currently are not. That would probably fall under the more of the breast center or our PT and rehab department. But it's a great thing. We also have within the institution the Integrative Medicine Center, which sounds very similar to our program, and it is, but they actually see the patients who are in active treatment. So that might be something that they would look at in their center.
Got it. Thank you for sharing that. Now, a question about the machine itself.
Yes.
Could you speak a little bit into what kind of maintenance it does require, if at any on your end, and if you believe it could be used reliably in a developing country?
Oh, absolutely. So on our end, we clean it between each visit, wipe it down, make sure we're sanitizing it. Other than that, it's been very little maintenance other than like making sure that the printer has enough paper and that we have ink. It's been super easy and super efficient to use. I guess in a developing country, as long as they had a power source and the ability to keep the printer stocked and with ink, I think that it would be very useful and available.
Definitely. And I know that we have, we do see it used globally. And of course, as you mentioned, it does need to be plugged into a power source.
Yes.
And I'm glad to hear that, the maintenance on your end is very low. So we appreciate that. Another question here for you. Does your center have an undergraduate student internship program for exercise science students?
So we do. We actually have a undergraduate and graduate position internship available. And so at MD Anderson, due to legality and other compliance issues, we have to have a contract with a school. So currently right now, our contract is with the University of Houston Clear Lake because they have a fabulous exercise science program for undergrad and graduate. So that's where we get all of our interns. We aren't able to get them from other schools unless we have a contract. And the contract takes about a year to execute. So it's not a very, very fast thing. And we also have undergraduate interns in the health education part of our center from Texas A&M.
Great, that's awesome. And again, if anyone is interested in contacting Whitney about this, her contact information
Absolutely.
is on the slide.
Yes, it'll just take some time.
No
We would love to have
worries.
more though.
Absolutely. And we definitely need, like I said, we need more people like you out there in the world for
Yes.
us. So with your background in, exercises medicine and as an exercise physiologist, of course, you explained, the more active you are, the more you decrease that risk for chronic diseases, including cancer, of course. have you seen more benefit from incorporating resistance training or cardiovascular training in your clients' programs?
So, personally, I think we've seen a little bit more, I don't know if we could say like benefit, but somewhat of an adherence with the resistance training, especially like in our female population, once they feel comfortable being in a gym or wherever, using weights or things, they get more excited about it. I personally, and I hope no one judges me for this, I dread cardio. Um, so I kind of lean more towards the strength training just because it's kind of my wheelhouse. But we also kind of keep it at an even base based on the guidelines to make sure that they are getting the adequate amount of cardio as well as resistance training.
Right. And I'm on the same page with you there, Whitney. Strength is king in my eyes.
Yes.
Muscle matters, right?
Yep.
Now,
Yes.
I believe you marked a certain percentage of subject to weight loss as an objective. We have a question here that says, wouldn't an overall loss of body fat be a better outcome measure to avoid the loss of precious fat-free mass in cancer patients?
Absolutely. I think so. That's a great question. And I've never been asked that before. So yes, I think that yes, that would be more beneficial because we don't want especially our patients in active treatment losing their lean muscle mass. We want to keep as much muscle mass as possible to kind of get them through their treatment. So seeing a body fat reduction in those patients would be much more important.
Right. And with the percent body fat value, of course, we do know, and I do want to make comment that it does reflect both those fat and skeletal muscle mass
Right.
changes. But yes, as you said, ideally, we want to track all of those.
Yes.
Regarding, oh,
Oh,
go
go
ahead.
ahead. Sorry. And I was just going to say, we don't see a lot of patients who are in inactive treatment. We tend to get them on either like the tail end of their treatment or once they're in survivorship. So we tend to see more of those patients than patients who are, in the trenches per se of their treatment.
Mm-hmm. And further to the parameters, from your experience, how reproducible are them? For example, multiple measurements in a given patient.
Reproducible as in how often should they, or are we doing it, or can you define that a little bit more?
I think the question from the audience was referring to maybe the accuracy of the measurements you are
Sure.
seeing, and back-to-back measurements. If you've tried doing that, what you've seen.
Yeah, so we have the only back-to-back measurements we've really done are on ourselves, just to kind of see how different they were. And I didn't really see a huge difference. We tell people to kind of come in, if possible, which isn't always easy to control, in the same state that they were the very first time they had their InBody. So if they had breakfast, eat a breakfast. Don't come in with your stomach full. Try and use the bathroom before we do it, so that it's ideally the same situation or state. That's incredibly hard to control, but we try and keep those things in mind so that we can get accurate results.
Great, thank you for sharing that. And I think it speaks to, how with the measurements, we are able to get those sensitive changes, which are very
Sure.
important to see, especially in clinical populations.
Yes.
Do you offer these services to breast cancer patients from other states by any chance?
If they came to the prevention center for a screening, but they do have to be an MD Anderson patient. So we get lots of out of state patients, and even international patients, intercontinental patients, but they do have to be an MD Anderson patient.
Got it. Thanks for that information. I have another question for you here, Whitney. Um, how do you set up and establish goals for your patients' programs? What particular values are you looking for, or do you rely on the normative ranges set by the InBody, especially considering the necessity of understanding each patient's individual needs and care?
Yes, so that's a great question. We in our clinic do a lot of motivational interviewing, and we kind of try and meet our patients where they are and not set goals for them ourselves, and we kind of let them create their own goals. And we try and set our goals based on like the SMART goal outline. So you want it to be specific and measurable, and time bound. So the goals are different for every patient. And the beauty of our Healthy Heart program as well is we get some patients who have never exercised a day in their life and are just, interested in being a little bit more active. So I get to kind of work with those patients. But we've also had several elite athletes, whether they were college athletes or even above that level, come through, and after their treatment, they just weren't at the level that they had been previously. So we've gotten to work with those patients to kind of get them back up to their performance level. So it's very different based on every single person that comes through.
Great. Thank you so much, Whitney, again for sharing, the great work you are doing within cancer prevention with us. At this time, we are coming to the close of our time together. So unfortunately, we do not have any more time to ask you any further questions. But again, we're grateful for you being here. And if you do want to reach out to Whitney, please use the email, which is shown at the top of the slide here. And to all of our attendees, we hope this was both informative and inspiring, and that you will consider joining us in future webinars. If you need to reach out to us, please contact us at clinical@inbody.com if you want to have a conversation with us about applications, or if you may be interested in sharing your research with us as well as other researchers through this forum. Also, please contact us if you need a certificate of attendance to apply for CPEU credits or CPE credits if that applies to you. And please stay tuned for our upcoming webinar from Dr. Lee of the City of Hope on the assessment of health-related outcomes in the field of exercise oncology.